So we're going to talk briefly about the termination phase now. So we've taken you through the initial phase, doing the inventory, getting a formulation, figuring out the work of the middle phase, and now we're going to move to terminating with the client. So the goals of the termination phase are to give up the relationship with the therapist, to help the adolescent continue to develop a sense of competence to deal with future problems, and to determine the need for further treatment. It's a short-term treatment, and so we don't believe that for many adolescents this will be a really difficult ending, but for some of them it may be, and so you may need to process it more or less depending on a given adolescent. Many of the adolescents are really excited to be done. They like you a lot, but they like hanging out with their friends after school instead, and so you can talk and model sort of appropriate feelings about ending. And for some teenagers who've had a difficult time with endings in their life, this is a way for them to experience a more positive ending than they may have experienced before, where the ending is expected and discussed along the way, and then feelings are processed about the relationship ending. When I say establish a sense of competence to deal with future problems, you've been doing that work all along. By them doing the work at home and the experiments outside of session, and by you commenting on the changes that they've made and linking it to mood, you've hopefully been sending a message throughout that they're able to do this work on their own. And part of what we try to do in the middle phase, as the middle phase progresses, is that we become less active. So in those first times we're scripting things, we may be giving a lot more suggestions as the therapist about what to say and how to say it. But over time, in session 7, session 8, we really want them to be the one generating ideas so that we're not lying when we say that they're ready to go and do this on their own. They've been able to show us that they can do it in sessions. They've been able to do it outside of sessions, and so they are really ready to continue this work. And we don't think that the work ends when treatment ends. We're hoping that we've given them skills that they can continue to use in their relationships moving forward. The other thing we need to do is we need to figure out whether they need more treatment. For many kids, 12 weeks of IPTA is enough to get them feeling better, and we'll show you some research in a little bit to show that that's true. But for other kids, it's not. For some kids, it's not the right model or approach. And so you may decide that, you know what, we've tried this, but I don't really get the sense that this is working so much for you, and so it's time to switch course. For other people, it's gotten them most of the way there. And so you may then have the discussion, you know, you're almost there, but booster sessions may be helpful. And to involve the parent in that discussion as well, because the parent may have very different feelings about the adolescent ending treatment. The strategies that we use in the termination phase to reach those goals are we do discuss feelings around ending treatment. We spend a lot of time talking about what strategies they learned in treatment, and we do this in a very specific way. So we don't want to just say, you know, generally, Tara, you really learned to talk to people about your feelings, but in particular in your relationship with Dad, I think it really helped a lot that you were able to acknowledge the role that you were playing in the difficulties, and that you were really able to express to him how you felt when he made those comments, instead of just rolling your eyes and assuming he understood what that meant. So for you, 2 really specific strategies were, you know, acknowledging your part and also using some I feel statements. And you also really figured out that it was important to find time to talk to him where you guys could have a nice quiet time to have a conversation. I then might review the strategies that she had worked on in other relationships as well. You want to review what efforts they've made to change and what their successes have been, and to really highlight their competence. And in this case, we saw change across a number of different relationships. She was able to improve her relationship with Eric. She was able to reach out with friends. She was able to communicate differently with Dad and start to develop that relationship. And so you want to review all the successes that they've had. And you can talk about how their successes and their changes have led to changes in the other person. So typically you will find as you're talking in the termination that they notice, yeah, you know, I'm talking more to them about my feelings, and I notice they're taking more time out. Dad's taking more time out to actually ask me about my day too. And so while we didn't address that outright, that's a change that I've noticed. Or I've noticed that my dad seems to be in a better mood with me and more comfortable around me. We're having more fun together. So pointing out how their changes in communication and how they interact with people have led to changes in the other person. You want to help them throughout the termination phase to talk about how what they've done generalizes to future situations. And depending on your work in the middle phase, some of this can happen towards the end of the middle phase where you've done most of your work on your primary problem area and can start to spend some time on some of those other relationships they've identified in their inventory as needing work. But you also talk about future situations that may come up that may be particularly difficult and help them problem solve in the moment how they can use some of the strategies that you've worked on to deal with those situations. So an example maybe for the case of Tara, that she has a Christmas vacation coming up and she knows that she's going to be expected to spend 4 days at her father's house. And so she's anticipating that that's going to be a particularly difficult time because there's likely going to be conflict about how she interacts with Sue's children. And so you may talk about how what we've learned and the strategies and really thinking about what it is you want to say and really weighing the pros and cons of how to interact, all of those may apply for that situation. You could also broaden it outside of the realm of the relationships you've talked about. So we know now that transitions may be difficult for Tara. She had a difficult time with the transition of Eric leaving. Well, what's it going to be like when she needs to graduate high school? Is that going to be a time that's difficult for her? And you might work on some of those things as well. So you don't want to anticipate problems that are going to happen 15 years down the road, but hopefully ones that are more proximal in nature. One of the things that we do spend time on in the termination phase is we talk about their warning signs of depression. So one way you know that someone's had IPT or IPTA is that they know depression symptoms as well as any counselor or psychologist because you've reviewed them with them every single week. So they'll often come in as you move to termination and say, my sleep was fine, I'm not depressed, my appetite's still bothering me, I had this problem making this decision, because they just know the questions. And in the termination phase, what we want to do is we want to help them to recognize what specifically for them, looking back, was a sign that they were developing depression or that their depression had developed. And we do this because we know that depression is a recurrent illness. And so if somebody has been depressed, they have a higher likelihood of getting depressed again. So we want the teenagers to be able to recognize those signs and symptoms in themselves so that hopefully they can get help sooner. And those might be very DSM-related symptoms, or they may be something really idiosyncratic for a particular client. And so you want to use what you know from their symptoms, but also ask them, well, thinking back, Tara, I know your symptoms really started at the beginning of the school year and really got worse at Christmas time. So what were those symptoms like at Christmas time that looking back may have been a sign? I noticed that I was sleeping all the time, that I really didn't have energy. I stopped wanting to go out with Eric. That was a real sign. I wanted to just sort of sit on my couch. Okay, well, if you start to notice that you're experiencing that again with some of the other symptoms of depression, that really may be a sign that it's time to sort of talk to somebody. It may not be that you need to rush back into treatment, but we've recognized that for you, when you isolated yourselves from friends and Eric, things got worse. And so maybe when you start to notice those signs, you need to push yourself a little bit more and spend more time with friends or spend more time with Eric or talk to your mom or dad about how you're feeling. And if that doesn't seem to be working, then that would be a time that we would recommend that you come back in for treatment. So we're not trying to be negative in the ending, but we want to be realistic that through no fault of the teens or no fault of the treatment, some teenagers will develop another depression, and we want them to seek help sooner. We also want to meet with the parent to terminate. Sometimes we won't have worked directly with the parent since the initial phase because we're working on a peer issue or because the parent's not involved or engaged. But other times we've had the parent be fairly involved in our treatment. They may have come for a middle phase session or two. We may have done a phone check-in. And so it's also important to terminate with them and to view their progress and how they view the treatment. So oftentimes a parent will come in and really be able to recognize some very big differences in their teenager, both in terms of their symptoms, but also how they're acting around the house. And there may be times where parents are reluctant for their adolescent to end, not because their adolescent isn't better, but because they're afraid it won't last. And so you can also talk to them about that as well. It's also important as you terminate to differentiate normal sadness from ending treatment from depression. And so sadness is a normal feeling that we all experience in our life. There are times when that's really appropriate, and it wouldn't be surprising for somebody to feel a little bit sad or a little bit nervous about ending, and to spend some time talking about how that's different from how they were feeling before. In terms of difficulties in ending treatment, there are lots of teenagers who don't really want to talk about their feelings about ending. They just sort of want to end. And sometimes attendance can become more problematic as termination gets closer. And so it's important, again, to remember that this is a treatment that tries to encourage direct communication. And so it's okay to model and talk about the fact that it's difficult to talk about ending, but also to encourage them to come in so that you can have an appropriate way of saying goodbye. It's not at all unusual in IPT, just as it isn't in any other treatment, for there to be a new crisis that emerges right when you need to end treatment. And I think that's a challenge that we all face when we're working with clients. From a research standpoint, we have the advantage of seeing people in cases and then doing their evaluation. So my best example is I was seeing a client, we were terminating, this was in the group program, and the girl had had a blowout fight with her mother. And she brought it into our very last group session. And not only was that a problem for her, but we were all trying to end on this very sort of happy note. And I really struggled with, do I keep moving on with the work I'm supposed to be doing in termination, or do I sort of spend time and derail and move to this girl's issue with her mom? And because it was a group, I really needed to continue. And so she had her evaluation a day later. And the way we do evaluations is they're blind, they don't know what condition they're in. So I was just waiting in this evaluation for her to talk about this blowout fight. That was enough for me to want to derail our session. Didn't even mention it. Was doing just fine. So I think the important thing to remember as we work with adolescents is sometimes we do have crises that are real, but sometimes we have crises that are meant to extend treatment, and many adolescents have a crisis of the day. And sometimes it is important for them to see, we're going to keep moving on in what we're supposed to do. It also sends the message that you're equipped to handle this now. We can spend a couple of minutes on it, but I don't think that this is a reason for us to stop. And so if those issues come up, you do want to talk about them, talk about what they may mean, and also encourage the adolescent to more clearly communicate their concerns about ending with the therapist. And again, that's another example of encouraging them to recognize their feelings and communicate their feelings. So when we think about termination, we think of it as session 10 to 12. Session 10 is a nice slush session. It can kind of be a little bit of middle phase work and a little bit of termination phase work. Typically, you have stuff that you need to review that's happened in session 9. So in our case, Tara and her dad came in session 9 for their parent session. So certainly part of session 10 would be reviewing what happened in that session and talking about how to continue to make gains. The nice thing about the termination phase is you can get the work done if you need to in a couple of sessions, but for some clients, they're really ready to move to termination right when session 10 starts. So in those 2 weeks, it's flexible about what you do when, but you need to talk about their feelings about ending therapy, discuss the possibility for recurrence and or the need for either current treatment or future treatment. You want to model a positive ending to a relationship, and you want to meet with the parents to review their progress as well. You can do that with the teen together. You can do that by phone or in an individual session with the parent. Any questions about termination before we move on to sort of general treatment issues, evidence, and adaptations? We purposefully are not spending as much time on termination because we think a lot of what we do is similar to how other people terminate, really with the difference of sort of recognizing the warning signs and really trying to build on what they've done and emphasize their strengths and competencies to do this work on their own. In terms of just some general treatment issues, a lot of this we've talked about as we've gone through the past couple of days. But we encounter many of the same challenges that you all encounter in working with adolescents. They don't just disappear because we're doing IPTA. It can be stigmatizing for adolescents to be in treatment. They may feel, as we've talked about, that it's their parent's problem, and so it's their parent who needs to be in treatment. And as we talked about yesterday, we often try to get them to recognize that they can make changes in their parent, even though their parent is in treatment. So we're not making any determinations about whose fault it is, but we're going to use them as the active agent for change, with the thought that that will then lead to changes in their parent. We experience missed appointments and lateness. I think partly because it's a short-term treatment, we experience that a lot less than you may if you're doing sort of an open-ended treatment, because they understand that this is for 3 months with the goal of getting them to feel better, and then they can go back and do their other activities. But we do address missed appointments or lateness, in particular in terms of how it interferes with our ability to do the work that they want to be doing and make the changes that they want to be making. We have had people who terminate early. We try to communicate with them our feelings about why we think they should stay in treatment, but that does happen. There are teenagers who are less forthcoming than Tara was, and they're reluctant to talk. They have some concerns about confidentiality and what will be shared. I think we reduce a lot of those concerns by talking to them about our confidentiality policy and really making explicit what will be shared with parent. And again, I think we reduce a lot of anxiety by actually having them present in that parent session so they can see exactly what will be shared. But for some adolescents, it may take longer for them to open up to you and to feel that they can trust you. It's always a challenge when you're working with a child or adolescent what your relationship is like with the parent, and I think that becomes increasingly tricky as the adolescent gets older. So if you're doing clinical work with a young child, there's no doubt that you're going to need to have constant contact with the parent, and they're going to be bringing them to sessions, and you may be spending a bulk of your sessions with the parents. So just really being empathic, I think one of the things that's really helpful is to recognize that you are only seeing the adolescent's point of view, and that there is no one side to a story, and recognizing how difficult it can be to parent somebody who is depressed or to be around somebody who's depressed, and to really work on building that relationship and to create an alliance that you're working together to help the adolescent rather than working against the parent in some way. We all have had cases where they're more complicated to treat because the parent has their own psychiatric illness, whether it be depression, substance abuse, or other things. We have evidence in the literature to suggest that we may really need to treat the parent's diagnosis first, but you can't always convince a parent to do that. And so you do need to be aware of how the parent's psychiatric illness impacts the relationship and impacts the parent's willingness and ability to hear things. And so when you have complicated situations like a parent with a psychiatric illness, you will likely do more of those individual sessions with parents to make sure that they're ready for the work. And you may also do a lot more work on modifying expectations for the relationship. And so that might be a time where you do try to change the relationship, but if that isn't working, to really try to talk to the adolescent about the fact that they may not be able to get their needs met in the relationship currently because of the parent's own psychiatric illness, and to talk about where else they can get that from. And then we've all experienced those parents who would like to do whatever they can to have their teenager not be in treatment with us. And so they may not be supportive. They may all of a sudden have a desperate need for their teenager to take care of their sibling right in the middle of our session. And so to try to talk as much as possible to get the parent on board for treatment, and also to get the teenagers. There are teenagers, we've talked a lot about teenagers who don't want to be in treatment, but a lot of depressed teenagers do want to be in treatment. And they can also advocate for themselves. They want to feel better. The nice thing about treating depressed adolescents is they haven't been depressed for as long as some depressed adults, so they remember feeling differently. And so to help them communicate to their parent how important the treatment is for them. We've had a bunch of questions from various people throughout the 2 days in terms of what would be an indication that IPTA would be an appropriate treatment and what might be an indication that IPTA might not be an appropriate treatment. So we just want to talk about that briefly. An indicator for treatment would be if the adolescent is presenting with a grief reaction, so they've experienced a recent loss. If there is family conflict between the parent and the child. If there's conflict with peers, either due to poor social problem-solving skills or social deficits, or conversely, if they have really good skills, but they're still having conflict with peers. If the intake report sort of suggests that they've had a recent life change that may be related to the depression, or if there's a really clear social precipitant. There are just those intakes that you read about And once you know about IPTA, I think they really scream, this would be a really good case for it. And the evidence to date is really for mild to moderate depression. We have evidence to suggest that IPTA is effective for more severe depression, but in that case, you may want to consider the combination of IPTA and medication. In terms of Contra Indicators, if we think about at the very beginning of yesterday when we talked about what IPT was developed for, it was developed for non-bipolar, non-psychotic depression. And so one of our first contraindicators is if they're actively psychotic, it's going to be very difficult to engage in this type of treatment. A number of you have talked about having clients that have comorbid substance abuse. We do believe that you need to treat the substance abuse first before you're able to treat the depression, and so that would not be you would not be recommended that you start with IPTA. If they're actively suicidal, we have lots of kids who we see with IPTA who are having some passive thoughts or who have fleeting ideation, or sometimes who have more severe ideation. But I think if you started with a client and that client was really suicidal, then we think that you need to address the suicidal ideation first, either through seeing them more frequently or hospitalization, and then it is okay for them to have some suicidal ideation, but if it's too frequent, you end up spending a bulk of your time on safety planning and not necessarily on the treatment, and so it's going to be a harder course of treatment to get through. One of the things we think about as we talk about is this a good treatment or not is what's the primary problem? And it's often hard to know. Sometimes we're figuring it out on our own. But if the primary problem is something other than depression, you may be better off treating the primary problem first with the thought that the depression then may resolve once the primary problem goes away. So for instance, if somebody has OCD and their OCD is really impacting their relationships and their ability to get out of the house, and so they have secondary depression, if you can treat their OCD, hopefully then their depression will remit as well. You've seen that this is a very verbal treatment. So it is a difficult treatment to do if a client has significant expressive or receptive language difficulties. We ask them to communicate their feelings in a clear way, and that may be too challenging for some clients. And so in the case of those clients, you may want to use a less verbal therapy. And then the other thing is that we haven't tested this treatment in children younger than 12. There is an adaptation that's currently underway by Laura Dietz, which we'll talk about a little bit later, that does work with kids who are younger than 12. It involves much more of a family component, and so it is a different treatment than what we've been talking about so far. The last thing is that this is an evidence-based treatment for depression. So I think it's important that they need to have depression. Oftentimes you'll get this intake and you'll be like, oh, this is perfect because they're fighting with their mom. This is a great IPT case, but they're not depressed. And if you think about what the initial phase of treatment is, it's a lot of education about depression. It's a lot of monitoring of symptoms. And so it doesn't mean that it won't be helpful for somebody like that. But when we talk about it being an evidence-based treatment approach for adolescents, it's really for depression. So we think about cases who are 12 to 18 years old. You can use this model with some adaptations with adults. Clearly, it's based on an adult model of treatment. We recommend that it be somebody who meets criteria either for depression, MDD, dysthymia, depressive disorder, NOS, an adjustment disorder with depressed mood. They just need to have some depression symptoms, and you can modify some of your language depending on the symptoms that they endorse. In order to meet criteria for depression diagnosis, you need to have impairment. So it would be somebody who's experiencing impairment either at home or in school. It needs to be somebody who is safe enough, that they're safe enough to be seen in a once-a-week outpatient treatment. And so if they are actively suicidal and require more frequent care or inpatient hospitalization, it's going to be difficult to do this treatment. And if there are these comorbid diagnoses, to make sure that you think that depression is the one of highest priority to treat. And sometimes it's really worthwhile to have a conversation with the client. It sounds like you've got a lot of social anxiety and also a lot of depression. We have different ways of treating those. What would they like to treat first, or what do they think is primary? In terms of comorbid diagnoses, we do not just treat really clean, super compliant, depressed kids. We do treat kids who have certain comorbidities. So most of the adolescents that we see have a comorbid anxiety disorder. We've seen some evidence that those anxiety disorders improve in treatment for depression. We think it's fine for you to see somebody who has comorbid ADHD and depression, but think it'll be a much easier treatment if they're stable on medication and their ADHD is being addressed. Again, this treatment is really for the depression piece, not the ADHD piece. Oppositional defiant disorder would be okay if they had comorbid oppositional defiant disorder and depression, and I think when you have a depressed adolescent, sometimes it's really difficult to disentangle those two because that irritability starts to look a lot like being oppositional. With conduct disorder, our experience is those kids don't show up for treatment anyway, and so we would really recommend that they get treatment for their conduct disorder first. Substance abuse, as I said, we would want you to treat that first. In terms of eating disorders, IPT is an evidence-based treatment for bulimia and binge eating disorder in adults, so there is a lot of evidence to suggest that it's an efficacious treatment. There is not evidence to suggest it's efficacious for anorexia, although it has been tested in adults. So if you had a teenager who had either bulimia or binge eating disorder, I think you need to decide on a case-by-case basis because we don't yet have a model of IPT for eating disorders for adolescents, but you can make the decision about whether you think you could proceed to treat their depression. And in terms of cutting or other self-harm behaviors, if they're cutting without suicidal intent and it's not a high-risk method, then you can decide on a case-by-case basis. We've had lots of kids who do cut. They're cutting with no suicidal intent, and they're not doing it frequently enough, or they're doing it somewhat frequently, and we would just monitor that as one of our symptoms that we're checking in on. Oftentimes, people are cutting because of an interpersonal event. It's very common for there to be an interpersonal trigger, which makes them upset or dysregulated, and they cut. And so oftentimes we will see a decrease in cutting as a result of addressing some of the interpersonal problems. Okay, I'm going to turn it over to Laura.
We started out doing efficacy trials. Now, efficacy trials are characterized by the fact that they are tightly controlled in terms of their conditions. We try and accept adolescents who we think would be most likely to benefit from our treatment. We do them usually in research context where we can control who the therapists are. We can pick our best graduate students. We can pick our favorite therapists to treat the kids because we're trying to see under the best circumstances whether this treatment will be effective. So many years ago, I did the first controlled clinical trial of IPTA for depressed adolescents. They were randomly assigned to IPT or what was called clinical management. And at that time, I was trying to mimic what would be an ethical waitlist control. Now, the beauty of doing psychopharmacological research is that you can have a placebo pill, but you don't have the equivalent of that in psychotherapy research. So for many years, if you look at the literature, a very common comparison condition for initial clinical trials was a waitlist condition. But as time went on, and especially for depressed teens, that began to be seen as something that was a bit questionable in terms of ethics for knowing somebody has depression and then asking them not to have treatment for a certain number of weeks. So in the adult literature, Dr. Weissman had developed what she called an ethical waitlist control. It was minimal clinical contact. So the kids in this comparison, the adults in the comparison condition, were assigned a therapist. They could see the therapist once a month. They were also seen by what we call an independent clinical evaluator, the person who administers the research assessments, who doesn't know what treatment condition the patient is in, who evaluates the patient. So in this waitlist condition, they had one therapy session a week. They would see their evaluator as well on other weeks. And if they needed an extra session, they could have one. But if they needed more than one more session with their therapist a month, they would be deemed as a treatment failure, that they couldn't be maintained in that waitlist control condition. The Institutional Review Board was a little worried about doing this for adolescents, whether they would call for their extra sessions if they needed them. So we increased the number of contacts that the kids had and basically ended up with a comparison condition of clinical management. They did have a therapist. They saw the therapist once a month. They had to see the clinical evaluator twice a month, so that only left 1 week of the month that they didn't have a face-to-face meeting with a clinician. And in that week, they had to have a phone call from their therapist to assess their symptoms on the telephone and decide whether or not they needed to come in for an extra session. So wait list turned out to be 3 out of 4 weeks of the month. They were seen by a clinician who reviewed symptoms with them and talked about what was going on with them, but refrained from giving any of the skills-based work that we were doing in IPT. So the kids were assigned to either this clinical management condition or IPTA, and they were seen every 2 weeks by the evaluator. And we found in our results that the adolescents who got IPTA reported significantly greater decrease in their symptoms at 12 weeks on the Hamilton Rating Scale for Depression and the Beck Depression Inventory. And they also had significantly greater improvements in overall social functioning and with friends on the Social Adjustment Scale self-report form. We also looked at how many of our adolescents met recovery criteria on the Hamilton. This is a criteria that was taken from the largest clinical trial at the time, the National Collaborative Study for the Treatment of Depression, which was a study of adult depression where they compared IPT to CBT to medication. And they used a Hamilton of 6 or less as a sign of recovery from depression. And we found that 75% of the adolescents who had gotten IPT had met recovery criteria at week 12 versus 46% of the kids who were in the clinical management condition. In addition, only 3 adolescents in the IPTA condition still met criteria for major depression at the end of the 12 weeks compared to 10 adolescents in the clinical management condition. So this was our first randomized controlled trial that suggested that IPT was a possibly efficacious treatment. So just to show you a little bit of the data, if any of you know about the Hamilton, a score of 15 or above on the Hamilton is considered a depression score. So our kids came in with mean Hamiltons of close to 20, 19 to 20, and those in the IPTA condition got to 6. Those in the clinical management condition were still symptomatic with a mean that was close to 12. And the Beck Depression Inventories showed a similarly greater reduction in depression symptoms for those kids who had received IPT. And this is the results from the Social Adjustment Scale. We showed significant difference in the conditions in the domains of friends, dating, and overall functioning. Interestingly, we didn't show a significant difference in their functioning in terms of their family relationships. And school is always a problematic domain because depending on when in the school year they're meeting with us, it's affected by vacations and summer and things like that. So at the time that I finished the efficacy study, NIMH was moving towards the concept of effectiveness research. Efficacy studies have been criticized for treating unrealistic populations that you as community-based clinicians would say, I don't see kids like that. They're too clean, they don't have a lot of comorbidities, they're much more compliant than our kids are that we see in the community clinics. So show me that your evidence-based treatment can work in a population more like the ones that we will see in our clinical offices. So I embarked on an effectiveness study where I was treating kids in school-based health clinics. And we felt that it was important to treat adolescents in the school because research shows that the majority of children and adolescents, 70 to 80% of them, actually receive mental health services in the schools. And adolescents are 10 times more likely to get care if they can access it in their school, because it eliminates the problem of depending on where you live, depending on your parent to transport you to your appointment. And some studies have shown that there's less stigma associated with getting interventions in the school, but we also know that some kids still don't like being seen going into the school-based health clinic. But more kids are willing to do that because there's a number of reasons that they can give for entering into those service sites. However, research-wise, at the time that I began this work, there was very little known about the quality of treatments delivered in the schools. There were some studies showing that they were superior treatments and the kids were doing well. Other studies were showing that whatever they were getting in the schools from various types of school counselors wasn't as effective as we hoped it would be. So it suggested the need to bring evidence-based treatment practices into these settings. So I embarked on another randomized clinical trial in school-based clinics. I ended up with 63 adolescents who were randomly assigned to receive IPTA or treatment as usual. Treatment as usual in the clinics was mostly supportive psychotherapy, largely provided by social workers with just one or two psychologists working in the school-based clinics. The schools that I was in were in impoverished neighborhoods in different boroughs of New York. They had primary care clinics located in the schools that not only provided mental health services, but they had pediatricians, they even had dental care. They were able to provide complete health care for kids who weren't insured, which many of our immigrant families weren't. So these are schools that are in challenging neighborhoods to have these kids come to school regularly, and these kids have many difficulties in their families. We randomly assigned the school-based clinicians within each school to either be, there were 2 clinicians in each school, and they got randomized either to be the treatment as usual clinician or the IPTA clinician. And we did a streamlined training. What I didn't talk about, another characteristic of efficacy studies is that we spend a lot of time training our clinicians before we allow them to have students or adolescents who count for the data. So we would have them treat 3 cases, they'd videotape each case, they'd have an hour of supervision for each session, they'd have to be rated as being very adherent before they'd be allowed to treat a study patient, because we were maximizing our efficacy. But you can't do that when you bring research into a community-based setting. So the community clinicians got a 1-day didactic, half of what you got, and then they started seeing their cases immediately, and they counted, and they got an hour of supervision from me a week throughout the course of the study. And we found in the school-based program that those adolescents who were treated with IPT showed, again, a significantly greater reduction in their depression symptoms on the Hamilton and the Beck Depression Inventory, and significantly greater improvement in global functioning. The CGI is what we call the Clinical Global Impression Scale, where the clinician, an independent evaluator, can rate how severely ill they think the adolescent is and how much improved they think the adolescent is from when they started treatment. The CGAS is the Children's Global Assessment Scale. It's a rating of global functioning in terms of school, home, friends, multiple domains. And again, the social functioning was measured by the Social Adjustment Scale. We also were able to look at how fast they improved, and we found that those treated with IPT had faster improvement in their symptoms and functioning. And you'll see in the charts I'm about to show you that the difference between IPT and treatment as usual was evident by week 8 of the study. And interestingly, the largest treatment effects occurred for the older and more severely depressed adolescents. This is consistent, the severity finding is consistent with the adult literature that has shown that IPT is quite effective with more severely depressed population. So we did a repeated measures analysis for the Hamilton Rating Scale, and as you can see, by week 8, IPT was already ahead of treatment as usual. We had an effect size of 0.5. And 50% of the adolescents who received IPT versus 34% of the adolescents who were treated with treatment as usual got a Hamilton score of less than 6 by the end of the study. Similarly, a repeated measures analysis for the Beck Depression Inventory. Again, the difference between treatment conditions was evident by week 8. And again, also on the social adjustment scale. So this was pretty important finding, because if you think about what you heard today, week 8 is almost at the end of the middle phase of treatment. They already were having a significant effect on their depression at that point in time. The other thing that I didn't mention about the model that we delivered in the schools is that the model we presented today is 12 sessions, 12 to 15 sessions, depending on if you have some extra parent sessions, in 12 weeks. The school model was 12 to 15 sessions, if you have the extra parent sessions, in 16 weeks. The first 8 weeks of treatment were delivered consecutively. So it was 8 weeks in a row, and then the school-based clinician had the option of how they wanted to use the last 4 sessions. If the adolescent wasn't doing well, they could continue to see them every week. If the adolescent was improved and significantly improved by week 8, they could start to use those sessions in a tapered fashion. So they could then see the kid every other week and begin to taper treatment towards the 16-week mark. So the implications of this school-based study was, one, that IPTA could be taught to real-world clinicians with varying levels of experience. Again, we had one-day didactic, and then they started treating the kids. We had clinicians, we had social workers who had been in the field for 40 years. We had social workers who had graduated from their master's program 2 years prior to the study beginning. We had people who were trained in Gestalt and humanistic psychotherapy, so we were asking them to do a very different type of therapy, but they all were able to learn and become competent in IPT fairly rapidly, and to maintain that with supervision just 1 hour a week, which is pretty minimal, throughout the course of the study. It was also nice to see that the modified treatment delivery and the 16-week model was also effective, and I think that's important. When we work with adolescents, we find that there are lots of different activities that interfere with 12 consecutive weeks of treatment attendance. So knowing that we can use this flexibly and it can still be effective is important. And lastly, I want to emphasize that IPT was efficacious with a minority impoverished high-risk population. IPT is one of the few treatments that's really been tested in this population. A majority of the clinical trials up until this time have been conducted with more middle-class Caucasian participants, and this is one of the few studies that has been done with a more high-risk, challenging, lower-income population with mild to moderate depression. So at this point, what do we still need to learn about IPT? One of the problems with our high-risk population is they're transient. They move around a lot, so it's very difficult to keep track of them and to get some long-term outcomes for how they're doing several years out from treatment. So that's still something we need to know. We also treated these kids with psychotherapy only. So in a randomized controlled trial, we still don't have data about who would benefit from a combined psychotherapy plus medication treatment arm, like they do in the TAD study, which showed that combination CBT plus medication is very effective for depressed teens. We do know from our clinical practice and our clinics outside our protocols that that is something that is very feasible, and I have a current study underway which will hopefully in another 3 years give us some information about the efficacy of the combined treatment and also the acceptability of such a combined treatment for the population that we tend to serve in the community at Columbia. As Jamie and I talked about earlier, while intuitively and based on adult data, we know that continuation and maintenance IPT sessions can be helpful in preventing relapse and recurrence. We again don't have that clinical trial data. Unfortunately, NIMH has to be willing to fund you and the time is right so that you can follow up your study patients as they finish their acute trial, and that has not always worked out. So we still don't have that data, but again, clinically and working in the child anxiety and depression clinic at New York Presbyterian Hospital, we frequently do continuation treatment, taper the kids, and I find it to be very effective. And lastly, how do other comorbidities impact treatment outcome? In many of these studies, approximately 70 to 88% of our kids have a comorbid anxiety disorder. A smaller percentage have had ADHD and ODD, but we really haven't fully examined the effects of these comorbidities in larger numbers on their benefits with IPTA. So that's another thing that we could do in the future. And globally, in terms of what the field knows and what still needs to learn about in treating depression in general, is as somebody asked yesterday, which treatment works best for whom? When should I treat my adolescent client with IPT versus CBT? We don't know that. It's a really hard question to study without 40 sites that would be needed to get the sample size. But there are talks of centers of excellence for depression that might make that possible, the same way they do that with studying medical diseases where you can't recruit enough subjects in one particular site. We also need more research, and I think this workshop is part of this. So what are the best methods to train community clinicians in an efficient, cost-effective manner in evidence-based treatment that will end up having clinicians conducting these treatments in a competent and adherent fashion? It's costly and time-consuming to come to get CMEs and to try and learn all these evidence-based treatments after you've already finished your graduate school training. And so how can we do that with a whole cohort of clinicians who've already finished their training, and how can we think about training another cohort of clinicians who's still in graduate school where hopefully we can bring more of our evidence-based treatments into their graduate school education. Another big question is, how effective are our treatments for ethnically diverse and socioeconomically diverse populations? As I said, one of the problems in so many of our clinical trials is that they have served a largely homogeneous population, so that NIMH has made a real push to try and enroll more heterogeneous ethnic minority populations into clinical trials, but there are challenges to doing that, and so we still need a lot of work to figure out how to better engage these populations in research. Many of these populations are suspicious of participating in research, but we need them to participate so we can find out whether they would respond better to other treatments and how we can increase their access to effective treatments once we identify them. And I'll turn Adaptations over to you.
So just to follow up, we've spent a lot of today really focused on the treatment model for depression, on IPTA specifically. And we just want to highlight that there are other adaptations of this model that are being used or being studied in different capacities. So Laura already talked about delivery of IPTA in the schools. We have developed a group IPTA model. In that model, the way that we do it is we see about 6 to 8 adolescents who have a depression diagnosis. Those kids have 2 individual pre-group sessions before the group starts. And in those pre-group sessions, we conduct a lot of the initial phase work. So we would provide psychoeducation in those individual sessions, and we would do the closeness circle and the interpersonal inventory. So before starting the group, we have completed the inventory and have specific goals for them to work on in the group. They then have 12 group sessions, and those group sessions are 90 minutes each. So we kept the 12-session framework, but because it's more kids, we increased the time from a 50-minute individual session to a 90-minute group session. And to help the adolescent with their work, we've also supplemented those group sessions with some individual parent-adolescent sessions. So in the middle of the group, the parent and adolescent would meet outside of the group with one of the group leaders to work on some of their interpersonal goals. And then again, at the end of the group, the parent and adolescent would meet with the therapist to talk about the progress made and the need for future treatment. So we do a lot of the work still in the capacity of the group. We talk a lot about the teen tips in the context of the group, and we work on their interpersonal issues just like you would do in an individual session, but you're utilizing the group members to give their feedback on thoughts about what might be helpful. It takes some of the pressure off the therapist because you've got teenagers who speak like teenagers, so you're not pretending to be one when you're really not, and they comment on how bad you're trying to be a teenager is. So it's helpful to have another teenager say, yeah, you know, that would work, or you could say it like this. So you really use the teenager. We also have found that it's really helpful and nice for them to be in a group together, to realize that they're not alone, and to use the group as sort of an interpersonal laboratory to practice their skills. Sometimes you can address interpersonal problems that are coming up in the group that may be indicative of problems outside of the group, and to give them a sense of community and hope that other people have these problems like me, they have some difficult interpersonal relationships, and they're working on them and seeing change, and I should try this too. We tend not to include kids with the grief problem area in IPTA-G. We could have a group that was separate for just grief, but it's very difficult to be in a group when you're mourning the loss of a parent and other kids are complaining about their parent. It's difficult both for the person who lost a parent, but it's also difficult for the people who are sensitive and realize, I really shouldn't be complaining about this because I have a relationship with my mom, and yet they need the chance to voice it. So we would probably at this point still recommend that somebody who had the grief problem area would be seen in individual IPT. So we don't have a lot of data on the group adaptation, although there was a NARSAD study that Laura had that I worked on that did some initial investigation into the efficacy of the program. For that pilot study, we compared IPTA versus the group model known as IPTA-G. What we did is it was a small study. We had 18 adolescents who were sequentially randomized to either treatment condition. So when you're doing a group-based study, you need enough kids at the same time to start a group, because you can't just say, hang on there, I know you're depressed, but wait 6 weeks for me to fill the group. So some kids would be randomized to individual, and then some kids would be randomized to a group so that a group could run. We ran 2 groups. There were 4 in the first group and 6 in the second group. And then we also treated 8 kids individually. So overall, there were 10 kids in the group approach and 8 individually. And it was a 14-week protocol. And again, this is just really pilot data, but kind of looking at those same criteria that Laura described for the other trials, we wanted to look at which adolescents, how many adolescents met recovery criteria using these criteria that have been set forth in other studies. And what we found, looking at the Hamilton rating scale, is that about 40% of the kids who received individual IPTA met recovery criteria on the Hamilton, compared to about 60% in the group. This is a really small study, so this difference isn't significant, but the one thing we see is there's some suggestion that maybe the group kids are doing a little bit better, but there's no suggestion that group is worse. And that's really what we wanted to see. Is there as much evidence of efficacy for the group program? And on the BDI, we see similarly that most of the kids, the majority of kids in both conditions, met recovery criteria on the BDI in either the group or individual condition. So I think there's enough evidence from this study to suggest that the group is certainly an approach we want to look at more. So I want to just talk briefly about the depression prevention program that I've developed and worked on in conjunction with Laura. And just to start a little bit about sort of why develop a preventive intervention at all. And so when I started getting trained in IPTA and really working closely with depressed adolescents, one of the things that I was shocked with was how long some of these kids had been depressed. And that even when they received excellent treatment in clinical trials, whether it be in IPTA, with medication, with CBT, that many of those kids had been depressed for so long that they really didn't see substantial improvements in their symptoms. And so I was interested in figuring out a way of intervening earlier. We know that very few people who are depressed do receive services. It's one of our biggest problems. When you interview people, they've been depressed for a while and they don't seek care, there's a lot of barriers to care. And those that do receive treatment, even the best treatment in clinical trials, about 40% don't improve. So we first have the access to care problem, and then even if you get great care, you may not get better. And so I think that really suggests a need to find additional services to augment treatment approaches. And the belief is really that prevention programs can reach a larger proportion of the population, and if they're efficacious, can prevent somebody from developing the onset of a disorder. There are different types of prevention that we can do. There are some people who have developed programs that can be applied universally to everybody. There are people who have targeted a specific risk factor. So there are prevention programs for kids whose parents are divorced, or kids who've lost a parent to death, or kids whose parents are depressed. But the last type of prevention, indicated prevention, is for kids who are showing some symptoms of depression. And the reason for looking specifically at kids with elevated symptoms is we know that elevated symptoms are one of the biggest risk factors for developing depression. We also know that those elevations are persistent over time. So yes, there are kids who have a bad week and have elevated symptoms one week and never again, but the majority of research suggests that these kids continue to have elevated symptoms over time. And they've also done research to look at kids who have symptoms of depression versus kids who are depressed versus kids who don't have either. And what they found is that even kids with symptoms of depression have very significant impairment, and in some ways don't differ from kids who are depressed. So kids who have symptoms of depression are still starting to show impairment in their relationships, in school, and other things. So there's really a rationale for kind of helping them both to get them feeling better currently, but also with the hope that that would prevent them from developing depression later on. And so I think there's been an increasing call for developing indicated interventions for depression. So all of that rationale led me to develop a group prevention program. It's called Interpersonal Psychotherapy Adolescent Skills Training. It's been predominantly studied as a school-based program for teenagers with elevated depression symptoms. It also has been studied as a universal program as well by another research team. We follow a lot of the model of the IPTA that we talked about, but it's a much briefer approach. So we still do 2 pre-group sessions, and in those pre-group sessions, we provide education about depression. We provide education about prevention and the purpose of the group. We provide information about what the group is going to focus on and really provide a rationale that when we're sad, it impacts our relationships, and our relationships impact our mood. And so the focus of the group is going to be on improving relationships with the hope that these adolescents will be less likely to develop depression over time. We then conduct an abbreviated interpersonal inventory. So we do what's done in IPTA in sort of 2 40-minute sessions instead of 4 45 or 50-minute sessions. So it's a much briefer inventory. And we try to identify specific goals that they're going to work on in group. And goals may be, I want to fight less with my mom about going out. I need to develop closer friendships. I want to spend more time with my father. So sometimes the goals really do correspond to the problem areas, but sometimes they don't. And then they have 8 group sessions, 90 minutes each. And the focus is much more on sort of psychoeducation and interpersonal skill building that can be applied across relationships. And so we don't focus as much on the problem area because we want to teach skills that apply, whether it's conflict with a friend, whether it's after a relationship breakup, whether it's after a loss, so that they develop a set of skills that they can use across relationships. And so a lot of how we teach it is in a more general framework. We've done 2 clinical trials of IPTAST, and we currently are doing a large one in New Jersey. Our initial findings from those 2 studies compared our group program to sort of usual school counseling. We wanted to approximate what typically happens in a school when a counselor knows that a kid is having mild emotional difficulties. The challenge is many counselors don't know that their kids are having mild emotional difficulties, and we're identifying them in this project through screenings and other ways. So in that sense, it's different, but we're trying to approximate what normally happens. And there was a lot of variability between schools and how often counselors were seeing kids who met those criteria. What we found in these two studies is that adolescents who received IPT-ST reported a greater decrease in depressive symptoms and an increase in overall functioning, largely from pre to post-intervention, with those gains being maintained up to about 1 year follow-up. Recently, we've looked at anxiety symptoms and found that our program also seems to be effective in reducing anxiety. So kids who are in our program report greater reductions in anxiety from pre to post-intervention. And then again, the real difference between prevention programs and intervention is we need to do long-term follow-up because it's not worth investing in these programs unless we can show that they're effective. And so we see that these effects persist to about 6 months to around a year after the program. And most importantly, the purpose of this program is to prevent depression diagnoses. And we do have some evidence to suggest that kids in our program are less likely to develop a depression diagnosis in the 1 to 2 years following the program. So I think that there's a lot of promising results for the program so far. Just to let you know briefly about other adaptations that are in progress, we briefly touched upon the fact that there is a treatment for adults which combines IPT and social rhythm therapy that's been shown to have a lot of efficacy in adults with bipolar disorder. And there is an adaptation that has been developed using IPSRT for adolescents with bipolar disorder. There's also a group in Washington, D.C. who's taken our prevention program and adapted it for girls who are overweight to look to see whether girls who participate in this program with some modifications are less likely to gain weight over time. And the rationale for developing that program is, again, that there is evidence in adults that IPT is very effective for binge eating disorder and for other eating-related behaviors. So it was thought that maybe this might be a good prevention approach there. That program does not talk about eating stuff. It's really focused on interpersonal relationships and helping the adolescents to recognize that their interpersonal relationships, when there are problems, may be a trigger to overeat, and that if they can address those interpersonal problems, they may be less likely to do that. There's also the modification we talked about already for kids who are younger than 12 who are depressed. And then finally, we're starting to look at a model, one of our colleagues is starting to look at a model of involving parents more, particularly in high conflict relationships. Kids who report a lot of conflict with their parents at the beginning of treatment, may it be effective to have them be involved in more sessions along the way. And all of these adaptations are in various stages of being researched. So if there's something that interests you here, we recommend that you sort of read up on them. And just finally, I think Laura alluded to this, but this IPTA is an evidence-based approach. It's listed on the list of legacy programs. It's considered an evidence-based program and an effective treatment for depression. And just finally, to thank you for your time and to acknowledge that there has been a lot of support for this work, for the research studies that we've described from NARSAD, NIMH, SAMHSA, and also from Columbia Department of Psychiatry. So we are open for questions, and thank you so much for being such an attentive audience.